Good morning and welcome. I'm Dean Miller, the President and CEO of PACT, and I want to welcome you on this rainy and stormy morning if you're in the greater Philadelphia area for our digital health series. This is the last in our program series for this programmatic year, and it's on AI bias and ethics in medicine. We have a terrific group of people to speak to this very important topic. But first, I want to recognize and thank our sponsors and supporters of this digital health series: Anexinet, Independence Blue Cross, Duane Morris, and SAP. By now, you're used to the process here. We are muted, all of us attendees, except for the speakers. Please ask questions, though. Drop those in the comments box, and we'll monitor those throughout and answer them. And we'll also have some time at the end, a little more free form for Q&A. The panel conversation will go to about 9:35, and then we're going to go into subject-specific roundtables. You'll have the opportunity to choose which one you want to join. You can even switch between the two. But here you'll go a little bit deeper for about 30 minutes into conversation around those topics and be joined with our speakers. With that, I want to turn the program over to our moderator, who's certainly an important member of Independence Blue Cross, the manager of data science at Independence Blue Cross, Stephanie Gervaisi. Welcome, Stephanie.
Thank you so much.
The floor is yours.
So I am, as Dean mentioned, the manager of data science at Independence Blue Cross. Have an incredible team that I work with. And one of the areas very important to us at Independence Blue Cross is working towards identifying and remediating algorithmic bias. And so with us today, we have 4 panelists who are very well prepared to give us a holistic discussion of this. If we go to the next slide, I'm very excited to introduce you to our panelists. And I want to say too, thank you to PACT for not only hosting this event, but for understanding how important it is to discuss this, especially a broad audience outside of the technical space. So we often get ourselves into a position where we're talking to other technical and clinical experts. And I think it's really important to take this discussion outside of that technical space. So to do that today, we have 4 incredible panelists. We have Jaya Aysola. She's the founder and executive director of Penn Medicine's Center for Health Equity and Advancement. Jaya is an assistant professor of medicine and pediatrics, and her research centers on evaluating system, provider, and patient level strategies to improve and update the quality of healthcare for historically marginalized populations. Welcome, Jaya. We have with us Dr. Seun Ross, who is the Executive Director of Health Equity at Independence Blue Cross. Seun is leading the development and implementation of strategies and interventions to ensure equitable whole person health at Independence Blue Cross, where we serve more than 2 million members locally in the region and over 7 million members nationwide. Irene Chen is joining us from MIT, where she's a PhD student in the Clinical Machine Learning Group at MIT's Computer Science and Artificial Intelligence Lab. Very excited to say that around this time next year, Irene will become an assistant professor at UC Berkeley and UCSF's Computational Precision Health Program. Congratulations, Irene. Her work centers on machine learning methods for improving clinical care and making it more equitable, as well as auditing and addressing bias in algorithms. Welcome, Irene. And finally, we have Ryan Wesley Brown, who is an associate at Duane Morris. Ryan is an attorney practicing in the area of health law. He counsels hospitals, pharmacies, and other healthcare facilities and providers on regulatory matters, including reimbursement, privacy, licensure, and fraud and abuse. And so I think this is incredible that we have these perspectives that are represented today as we dive into this very important topic. And so before we begin with panel questions, what I'd like to do is ground us in the topic for today. So this digital health event series is AI, or artificial intelligence, bias and ethics in medicine. So what we're really talking about today is how algorithms or sets of rules or problem-solving operations can create biased predictions and lead to a reflection of and an amplification of systemic and institutional biases, particularly so when they're inappropriately or carelessly applied. So algorithms are great. You hear a lot about them, and they probably impact your daily life much more than you're even aware. They help find patterns, detect anomalies, identify relationships among massive amounts of data, things that we could never do with our human brain. Algorithms allow us to do. One of those common interactions we probably have is with sites like Netflix, where our own attributes and our previous viewing history helps to dictate future patterns and what we might like to watch, favorite shows or favorite movies. But algorithms are increasingly being used in other ways, including surveillance, where facial recognition is being used to identify individuals. And AI and machine learning are used widely across the healthcare industry for a variety of clinical and business use cases. So we commonly apply algorithms and techniques in pattern recognition to do tasks such as predicting who's likely to develop a disease, who's likely to need care at an emergency room, and who should be prioritized for screening and high-touch care. So while that's the positive side of algorithms, allowing us to sort of extend our own human brains and expertise, there are unintended consequences and harms that can come from using algorithms indiscriminately. So when we think about making a bad movie recommendation, not too much potential for harm. But when we think about how algorithms are used in things like facial recognition, there's a potential for unfairly accusing someone and perpetuating racism and fundamental drivers of health inequities experienced by our families, our communities, and our society. So algorithms developed without evaluation and investigation for bias can cause harm. And in fact, that harm is disproportionately borne typically by those who are already marginalized in our community. So today we'll discuss this issue of bias and ethics in medicine and in healthcare with our experts, and what can be done to work towards fairness and equity and other data-driven approaches. And so with that, I'll start with the first question that I have for our panelists. And this question is the same question for each of our four panelists. I'd like to start with Dr. Seun Ross. From your perspective and experience across your respective roles, how does the topic of algorithmic bias, fairness, and ethics in healthcare pertain to, influence, or impact what you do or what you oversee?
Well, I'll say that honestly, bias is present in the world. And if it's present in the world, it will be present in the data. And it will be learned in some form by machine learning algorithms. Simply hiding or protecting certain variables won't be sufficient for reducing algorithmic bias, and their influence will persist in the data. In healthcare, practical examples of biases are frequently based on gender or race, and they shape a plethora of vital diagnostic and therapeutic decisions, leading, for example, to the classic case of a missed MI or myocardial fraction in women, which do not show, that women don't show the typical symptoms of a heart attack that men show. And another well-researched case concerns like psychiatric decision-making in Black populations. Black people are much more likely to be diagnosed with schizophrenia when presenting with affective symptoms than their white peers. And white patients presenting with similar symptoms are in turn more likely to be diagnosed with mood disorders such as depression. And this persistent phenomena of mixed diagnosis is thought to arise from the socially entrenched biases passed on by clinicians. Other examples include widespread misperceptions about pain management in Black people based on the erroneous assumption that physiologic differences between Black and white people, and the rise of machine learning in medicine runs the risk of exacerbating such biases. Since structural racism is known to shape the collection and the integration of data, as well as the delivery of therapeutic interventions. So, for example, if one were to use the historical health records of Black patients being treated for schizophrenia in the US to train a machine learning program, it would arguably use race as a predictor for its calculations and continue to overdiagnose schizophrenia in its recommendations. However, one would not only risk communicating false clinical judgments from the past and end diagnostic machine learning programs. So I think more problematically, if such procedures were to be dignified by the common belief of the objectivity of algorithms, discriminatory practices would become even more entrenched in medical practice and more difficult to address. So existing biases could become deeply hidden beyond the grasp of human understanding, as you mentioned. What this can do is more than what our brain can do. And so algorithmic bias would skew the recommendations systematically for one particular group, resulting in unfair treatment.
Thank you, Sean. So that was such an incredible recap because you detail a few specific cases, but this is clearly a pervasive issue that won't be solved by changing one algorithm or working on one specific condition. And so I appreciate that breadth of, just how pervasive and how big this issue is. Jaya, I wonder if we can hear from you next, because you and Sean both have this clinical expertise that I think is so incredibly valuable to this conversation.
Sure. And good morning, everyone. It's great to be with you this morning and talk about this important topic. To echo what Sean or Dr. Ross said a minute ago, this isn't a pervasive problem. If we think about algorithms and its widespread use in medicine, and if you think about what they're doing, and they're taking current state data to predict future state. And if our current state data and the way we practice medicine right now is unequal, and it has bias baked into it, our future state will undoubtedly be unequal if we use our current state data to predict what future state will be, or to guide future actions based on our current state. And so when we think about ways in which to overturn unequal care, unequal treatment, and unequal outcomes, or inequities in health, which is what drives my work, this is a critical component to mitigating that, right? So you have to think about the ways in which we can understand how bias is baked into the current state, and then understand how bias is baked into our current state data, and then sort of flip the script and narrative. So there's a way in which, and I think we'll get to this later on, that we can use algorithms to be almost diagnostic. So we can figure out where our biases are with machine learning, and then subsequently almost bake in countermeasures to then, get to a more ideal state. And even beyond machine learning and big data, clinical algorithms, or any sort of algorithm that is sort of guiding our actions right now as physicians or clinical providers, they're only as good as the science that informs them. And if our science is based on misconceptions like race as a biomedical term, or gender as a biomedical term. So in other words, when I say this, what I mean by race as a biomedical term is that we have been conditioned and taught in medical school, and subsequently been trained to believe that when we see race-based differences in care and care outcomes, that those race-based differences are due to something intrinsic to that race, or something innate to that population. But nothing could be further from the truth. Now, with more knowledge about genetics, et cetera, what we've learned is there's more differences in biology and in genetics within one group that we classify as one racial category, like white, than there is between groups. And so there's really only one sort of human race. And we all have very similar biology and genetics, yet we have operationalized race in medicine as if we are distinct populations. And thereby, when we see differences and when we think about race-based science, we're thinking about it with race being a biomedical term. And I say all this because as we go and talk more deeply about this, and when we think about the bias baked in, a great majority of the race-based bias baked in is stems from that fundamental flaw in understanding of what race is and what race-based differences really mean. And we have to sort of undo that as we think about the processes to sort of undo what algorithms sort of perpetuate in medicine. And I'll pause there, Steph, and I'm not sure at this point whether I even answered the original question.
That's amazing. Yes, and you covered so many. I'll just say, like, the focus on data, the focus on the science itself, because I think, you know, as someone who has a scientific training, we sometimes see science as flawless, right? It's gone through peer review. It must be correct, but that's not always the case. The idea that fundamentally we are using data to make these decisions, and if we don't understand how those data were obtained, what they actually represent, that right can create biases. So I love that you've sort of already touched on these different places where bias can exist. And then you've also done something really important that we're going to come back to, which is, what do we do about this? And some of it is, what does training look like professionals, right? For professionals, whether we're talking about someone who works in a clinic or someone like me that sits behind a computer and codes away. So that must be part of the solution. But there's also, as Sean mentioned, this is systemic, this is, you know, structural, this is institution level. So we need to be doing multiple things. So thank you for that introduction. And I want to pose the same question to Irene, and Irene is coming from a different space. So this is what I love about this panel, is now there's different perspectives represented. So Irene, tell us about your perspective on this, how you interact with this idea of algorithmic bias and how it impacts your work.
Absolutely. So I study the algorithm development process. I develop new machine learning methods designed to see what's going on bias-wise and how we might go about ameliorating it. And the thing that's crazy is that studying bias, you think it's its own sort of field. There's machine learning, and then you want to tack on some bias work at the end. And it turns out that all of the things that make bias occur are sort of core fundamental technical challenges that show up in machine learning. So the fact that we might not have enough data for some groups, or we might not have consistent labeling methods. We might not be confident in what we're using to say, oh, this person definitely has diabetes, or they definitely don't have diabetes. What if they do have diabetes, but we just haven't diagnosed them yet? How do we build that kind of uncertainty into the model? How do we say, okay, we know there's something going on, but how do we estimate what the impact of a specific action would be? All of a sudden, we're talking about causal inference techniques as well. So sort of one of the things that I'm very excited about is that in this world of machine learning for bias in healthcare, you sort of end up doing machine learning on hard mode, because healthcare data is messy and noisy in all kinds of different ways. And then also bias work is also messy and noisy in all kinds of ways. I want to highlight a few different existing works out there that I think have been very fundamental in shaping how we talk about developing techniques for mitigating algorithmic bias. One of them is this Obermeyer et al. Paper, which many of you may have heard of, where they looked at case management algorithms to determine if you're using the right labeling. Should we be predicting for health need determined by health utilization, or health need determined by costs, and how would the impact manifest for different races? Spoiler, there's some bias there. We also have, myself and some other co-authors, we've looked at chest X-ray algorithms. So here are giant data sets, the largest you can think of, with these giant images. And even then, when we start looking at different groups and how one diagnosis algorithm performs for certain groups, we end up seeing that for smaller groups, for intersectional groups, there are in fact disparities that we would not want to magnify by blindly, applying this algorithm widely. So overall, I'll sort of sum up by reiterating what has been discussed a lot, which is that science can be flawed, and it is shaped by the scientists who are performing the analysis. And I'm so glad that there are panels like this to start thinking about what are the areas we need to bring in, how do we know what we're doing well as well, and how do we know what the areas that we need to improve in.
Thank you, Irene. And I love that note that you finished on, which is we need to know what we don't know, and we need to have the right experts and voices represented in what we're building. So we talk about these algorithms that we're building for populations. How are we incorporating the voices from those populations into our work? That's, you know, sort of a common piece that's left out, but this is a technical solution, but there's social aspects to it. And yeah, thank you so much for that grounding. And now I want to turn to Ryan and the same question. So Ryan, you deal with issues of privacy and protection, and thinking about HIPAA. Tell us, for these algorithms, you know, how do they impact the work that you do, and how do you think about this issue of bias?
Sure, thank you. So yeah, as an attorney, I think it's really easy to sort of hear all of this really interesting technical explanation, and you know, there's a temptation to just sort of let your eyes glaze over and kind of think, oh my God, how am I ever going to tackle this? And one of the disadvantages that we have as attorneys is that, particularly in healthcare, and when we add a layer of technology on top of that, we are always playing catch up. The law is very slow to develop. And a lot of that's by design. You know, you can get into a whole discussion about whether the law should move quickly or slowly, and which you prefer. But like it or not, we have a very slow moving process. The result of that is that we have a lot of really old laws. And I'll really, you know, get into this later in more detail, but one of the primary laws that we deal with in this space is HIPAA and the subsequent sort of regulations and amendments that have happened. And something I like to point out to people is that HIPAA was originally passed in 1996. And in 1996, almost all medical records were paper records. So this was a vastly different world than we live in now. And, you know, despite the fact that we have made some amendments and some updates along the way, we really are using this very sort of outdated, blunt instrument to try to deal with these really complex new issues. And, you know, one issue, just to preview, that we see in the area of AI is, how do you appropriately de-identify patient records to protect patient privacy? There was a really interesting case within the past year or so out of Illinois, where an academic institution provided medical records to a very large tech company as part of an agreement for some research work. And they were ultimately sued. The health system of this institution was sued by a patient because the standard under HIPAA for whether something has been or is de-identified to say that it's a breach of someone's privacy is not whether it has been de-identified, but rather whether it could be de-identified. And the theory there was, this company has so much personal information about everyone, because we all use it, that they could theoretically use all of this outside information to piece together who these people are based on very small slivers of data. Ultimately, sort of for some procedural reasons, that case was dismissed. There's possibly an appeal pending. We'll see what happens. But it sort of goes to show you how gnarly of a legal conundrum this is. And there are some bright spots. We have seen California's privacy laws do include a requirement in all contracts having to do with AI and data that, not just AI, but it's broader than that, data, that essentially the users cannot pull together data from outside sources to then compile together with the secure and private data that's being exchanged as part of the agreement. So, you know, there are developments, but as I said, it's slow. And, you know, we'll just have to sort of hold our breath and see what happens. But I'll get into a little later. There are steps that we can take as attorneys to kind of address this.
That's such an amazing perspective, and one that's so valuable to me, because I feel that I should know more about this, the legal aspects. And so I really appreciate that you're here to discuss this with us. What it feels like to me is the slowness is not apparent to me, but it seems that we find, because a lot of these approaches in artificial intelligence and machine learning are so new, that we identify a really serious problem and that that's what's precipitating the legal action rather than the other way around where there's preventative before we deploy and use these things, there is some kind of protection. So to me, it feels always a little bit, scary in that what do you find that then precipitates this response legally versus how are we embedding in the building and development of these tools protections that are, conservatively protecting and preventing any potential harms that could arise. So thank you so much, Ryan, for your response. So what I'm going to do is I have some questions for individual panelists. And Jaya, I want to come back to a note that you mentioned in this introduction. So in 2021, you published a paper in the very prestigious New England Journal of Medicine called Misrepresenting Race, the Role of Medical Schools in Propagating Physician Bias. And you and your co-authors have a statement that I think is really profound that I'm going to read and then sort of ask for a response to. So you say racism shapes social experiences and has biological consequences. Race is not a biologic category based on innate differences that produce unequal health outcomes. Rather, it is a social category that reflects the impact of unequal social experiences on health. Yet medical education and practice have not yet evolved to reflect these advances in understanding the relationship among race, racism, and health. And I'm thinking back to some of what Ryan has just shared with us and seeing something similar in that last part of the statement. So can you describe for us, and you've started this discussion, some of the flawed biases that have shaped medicine? You talked a little bit about these race-based adjustments. Not just why do they exist, but how widespread are they? And what are some ways that clinicians can become more aware of this?
Sure. So yeah, I smiled too when Ryan said the law lags behind, because medicine lags behind too in terms of its understanding and use of race. So in the 1990s in Ann Arbor, anthropologists, famously dismantled race as a biomedical term or a biomedical construct. And they said, really, to define people by one characteristic like skin or hair texture, without a deeper understanding of what's common between us and how intrinsic to us, our biology, our ancestry, our genetic predisposition of disease cannot be determined by one's appearance or some simple trait like skin color. And that continues to be true with advances in medicine and our ability to now map out the entire human genome only to find the exact same thing 2 decades later. And for us to keep looking for some sort of genetic explanation for the differences between races when it comes to health outcomes and coming short. And if we don't do a deep dive into all of sort of the ways in which we practice medicine, generate race-based medical science, impart medical science in that way, and then apply it in practice, we're going to continue to have bias baked into the way we deliver care, and thereafter bias baked into our prediction models that sort of help guide care in the future. Critical examples, I think one of the things we have to understand is if we start to see differences by race, but we know that's not intrinsic to genetic predisposition, lack of personal agency, or anything innate to that individual population, we have to ask the next order question. Well, then what is the difference? What is race a proxy for? And when we start to look at that, we realize that race is truly a proxy for structural racism. And what do we mean by structural racism? We often think about racism and it's a really charged word. We think about it in terms of interpersonal racism and we think, well, I'm not racist. But when we think about structural racism, what we're saying is that our social systems in society, the way in which we've designed society, from our educational system to our healthcare system, is intrinsically biased towards one population, unintentionally sometimes. And while medicine is is well-meaning and our providers are operating in a well-intentioned system, that system has been generated by a single cultural perspective. And that single cultural perspective is that historically of a white man. And so then your system is designed to benefit that population over all others. Also, if that perspective is the only perspective generating the science, as Irene alluded to, you can sometimes get a singular perspective defining your science, and your science can be biased in that way. And a biased science leads to biased algorithms. And so that sort of has created the state of affairs that we're operating in now, where you have race as a social construct, but it's being operated as a biomedical construct within our healthcare system. I can give concrete examples or I'll stop. I was going to lean into a couple of examples that people often talk about, but I can stop stuff and do that later. You tell me.
Maybe give us one of those examples, Jaya, and I appreciate this focus. I'm thinking of this now as an analyst, this idea of race is a proxy for structural racism, and how often do we ground our analytics with that framing and through that lens, rather than oversimplifying something that is extremely complex, but should be out in front, right, for discussion. This is the representation that we're seeing, whether it's on a medical chart, in an EMR, you know, when we click those boxes for someone else, or someone else chooses their attribution, how is it downstream kind of percolating through our actions toward them and in service of them? So maybe if you could give us one of those examples, I think that's so useful to kind of illustrate how this is operationalized and how it works in that setting, at a person-to-person setting.
Sure. So I think I'm going to lean on one of the most talked about examples, which is correcting a kidney marker or a marker for kidney function, EGFR, by race. And I'll talk about the genesis of that in a second, but essentially our journey towards correcting race or kidney function by race occurred with, again, flawed science. It was a small sample study. It was highly skewed. So it was far more white patients in the study than people of color. And they found some differences that they attributed to biology. And that attribution got baked into our clinical guidelines and our ways in which we correct for kidney function. And when we say correct for kidney function, what the race-based correction factor is doing is, if you have a certain creatinine, which is a laboratory marker that tells you gives you some indication of someone's kidney function, they're taking that value and they're raising the threshold for concern for Black patients only. So in other words, for the same exact creatinine level, where you'd be highly concerned and want to refer a patient to a nephrologist or a kidney specialist, or even more serious for a creatinine of 1.3 perhaps, where it's very low, where you would want, it would be an indication for a renal transplant. That raised threshold of concern, if applied to Black patients only, they would not be referred for a kidney transplant. So it actually exacerbates what we know are underlying disparities in transplant referral that we already see, that are made worse with this raised threshold for Black patients only. And when we think about how that's operationalized, even in a setting with folks that are multiracial and ethnic, with folks that may not even appear to be Black, their skin color or their physical characteristics don't really match their self-identified identity, it is really just even practically hard to implement in a clinical setting. But then it's also fundamentally flawed in its understanding. And so that's a salient example of how this can sort of be baked into our care to then provide unequal care and unequal treatment.
Thank you so much for illustrating that. That example, I think, is just so profound when you think of the potential outcomes of someone ending up on a transplant list or not, based on race, based on these faulty assumptions that come from a flawed scientific study. So thank you for walking us through that. Seun, I want to hear from you. And I want to pivot a little bit and talk about this challenge at scale. So Seun, you're a licensed registered nurse, a nationally certified family nurse practitioner, and you're our executive director of health equity at Independence. You lead us through a lot of really difficult and challenging work. Can you talk to us about those challenges of dismantling the structural and institutional biases in healthcare, specifically in an effort to work towards this member-centric vision, these members who we insure, to advance health equity? So how do we meet that challenge of thinking about this at scale and the levers that we're able to pull, or you're able to pull through your leadership at IBC?
So just, to piggyback off to Dr. Aysola, no socially constructed race has superior health outcomes compared to any other group in all measures. However, race remains a factor in health disparities research, and this harms us because it perpetuates the falsehood that whites are superior, and it prevents medicine from addressing those health disparities experienced by all racial groups. It obscures the true cause of poor health outcomes, which is racism. And the continued use of race, whether biological or social, in medicine, and the identification of whites as the control group are examples of racism. So biological race is not supported by genetic findings. Back in the 90s, there was the researcher that came to the White House and declared to the whole world that we are 99.9% the same. But those findings are linked to the genes that affect health, yet it continues to be used, race that is, continues to be used as a factor in health disparities research and medical guidelines and standards of care to denote a superiority. Additionally, using social race without explicitly mentioning its connection to racism allows people, clinicians, to ignore racial hierarchy in the ways that it impacts health outcomes. So dismantling the system of racism in medicine that reinforces this racial hierarchy won't be easy, won't happen overnight. However, we cannot continue to allow racism in medicine because it corrupts knowledge production. It limits access to equal treatment, and that inevitably harms us all, no matter what you identify as. So instead of using race as a measure for health disparities, research guidelines, standards of care, I think that using social determinants of health and other factors like your neighborhood, based on zip code, your education, your occupation, your whether or not you have health insurance, your income, your wealth, health behaviors, how you experience racism, SOGI, your sexual identity, your gender identity, your disability status and your age are more important indicators. And just so that I'm clear, I'm not suggesting that we adopt this colorblind approach, because I think this ignores the impact of racism on healthcare outcomes and inevitably will reinforce inequities. And I am 100% in support of continuing to collect self-identified information, because again, that just helps us understand how all of this impacts, all of those social determinants impact people and based on how they identify. Health disparities research that includes social race should include statements like, the lack of access to healthcare due to racism caused differences in health outcomes for all racial groups. I think we need to continue to track the social race of healthcare providers, clinicians, to identify the ways that racism prevents racial and ethnic minorities from becoming healthcare professionals, because I think provider-patient concordance is one of the best ways to create health equity. I think finally, you know, the best outcomes should be used as a model for other groups. Say, you know, if Asian people have, and this is totally hypothetical, but if Asian people have the best rates for blood pressure, then we should use them. We should not continue to defer to one group consistently.
That's there's so much there, Sean. And I'm so proud to have you as a leader at Independence, both for the work that we're doing internally. So much of what you're saying reflects how we do our job internally in analytics to support our efforts. And so much of what you're saying is important externally in our relationships with our providers and our members. And so it is thinking about, these are the perspectives that change our policy, that change our processes, that pull these levers internally to change how we collect data, how we use it ethically, how we report it out, and all of these things are part of that solution. So thank you for expanding on that for us. I'm gonna pivot again to Irene, and I wanna come back to Irene's expertise, which is these methodological tools that we can use, that we can both develop because she's an innovator, and then that she is making available to others. And I think that that's a piece I want to just, you know, leave this group with, is that a lot of the work that Irene's doing is open, accessible to others. And so it empowers other scientists to do these things and incorporate them into their work. And that's so important because science feels sometimes very cloistered, that we, you know, we do these things and we keep them to ourselves, or they're behind a paywall. And so Irene has been amazing in terms of creating things that others can apply, whether we're in, you know, a healthcare setting or outside of a healthcare setting. So Irene, can you tell us a bit about how, as a developer, you can use these technical and non-technical approaches to identify and reduce bias? Can you give us some examples of the techniques that you might apply to first investigate, really thoroughly kind of interrogate what you're doing, the entire pipeline, and then change things or tweak things? I think, Jaya, you mentioned this early on too, like how can we use to our advantage the things that we know about potential biases, and even get to things that we maybe don't anticipate? So talk to us about that, those technical approaches.
Absolutely. I think maybe one way to phrase this is things that we have tried in the past. I'll walk you through the history of algorithmic bias and how researchers like myself have thought about this, and then maybe highlight some things that have not worked out and how we arrived here. So one of the first things people say to me, and also a thought that I had very early on, which is, you know, maybe we shouldn't include race. This is something that we have talked about in this panel already, but that the sensitive attributes, as we call them, race, gender, any kind of protected group that we as a society have made legal claims and are legally protected groups, maybe we should just not put those in the data that is fed to the algorithm. What happens though is that a few things might arise. One is that the race information, even if it's not specified in the actual data as like a race column, and here the information is, can be encoded in other ways, most directly maybe in a zip code, and that we have that information available to the algorithm without us knowing that it's available. The other thing is that that race information may contain information that might be helpful for prediction, that we would want to further investigate what's going on there. So in general, I think as a field, we've moved beyond this fairness is blind concept. So if we just remove the thing that we don't want to know about, then we're probably okay. And now we're starting to say, oh, we should probably measure these protected groups. We should probably start auditing what's going on, use these in our audits to see, hey, how are we doing for this group versus this group? And we can't do that if we haven't measured it in the first place. So those are sort of we're starting to put those best practices in. The next question is sort of, how do we define bias? How do we define fairness in the first place? This is a very tricky question that philosophers have taken various attempts to define over centuries. In the algorithmic bias space, we've sort of solidified on a few different ones, although I did recently see a paper that's like 21 definitions for algorithmic fairness, and I'm sure it's doubled since then. But a few ones that come to mind are the idea of looking at how the model performs on different groups. So we might look at something like false positive rates and false negative rates and compare those across the groups in question. If we're not so interested in the amount of groups, we're not so interested in love with our definition of the type of groups, there's also something called individual fairness, which designates that similar people should be treated similarly. So you can define some sort of similarity metric and say, oh, I have these blood pressure readings, I have these lab test readings, and then I should be treated by the healthcare system in a way similar to someone else who has a similar kind of health profile, and we should have similar outcomes. And if that's different because of socioeconomic status, race, anything else, then all of a sudden there should be a red flag. Oh, what's going on? That when we go through the algorithm, we're being treated differently, even though we are being observed to have very similar kinds of health profiles. So those are sort of two types, group-based fairness metrics, and then individual types of fairness metrics that we're going through. The problem with individual fairness metrics is this similarity metric is actually quite challenging, and people disagree on how to compute that as well. And then I guess I'll lastly sort of broadcast forward all the things that we'd like to continue working on. One of them is going even beyond, okay, let's get into the math and the weeds, and that's where people like me love being, which is all in the math. But if we zoom out, the reason these kinds of biases occur in the first place is that the data we collect is kind of wonky, and that the problems we might define, saying, oh, let's look at this specific type of disease, these specific types of people, all of those get brought into question in questions of equity. We overstudy some diseases and some populations in this country because of access to the healthcare system and because of the way funding is allocated. How can we rethink that? How can we even use machine learning to start to better examine a wider swath of diseases and subpopulations and patients for improvements in equity in healthcare? So I'll sort of leave a thought there of sort of how could we think about this as glass half full, which I hope we'll get into discussing either now or in the breakout groups.
Absolutely. Thank you for that perspective, Irene. And thank you for coming to that final point. I think too, here we've arrived at another system level thing, right? Where's the grant money going? What is well studied? What type of care, what type of diseases are, well funded? But I want to reflect on this point that you talked about, looking for similarity in the performance of a model. So when we build these machine learning models to do some prediction tasks, we can ask overall how well it does, or we can ask by group. So you introduced, thank you for these definitions of individual and group fairness. And I think that what I want to leave the audience with is the idea of, are there similar or different error rates can have really profound effects, right? So a false positive versus a false negative, we might hear that and think about it, what does it actually represent? Well, if we're predicting whether or not someone develops a serious condition, a chronic disease, the one type of error we can make is to say this person's likely to develop the disease, but they don't. They stay healthy. But the other type of error we can make is to say, this person's fine. You know what? They don't look like they're going to get sick. We don't think they're going to get sick. And they actually do get sick. So I use that as a really, to try to make this example of the types of errors that we make with these prediction models, the way that we're optimizing, the choice of optimizing for whom is so important. And so Irene has really spoken to this idea of how's a model performing, but not overall, but by these groups. And how do we think about the types of error that the model itself is making and what we'd rather make. Life is a trade-off, right? You can't have everything. So what are the errors that do the least amount of harm? And so being a good developer, a careful developer, a thoughtful developer means thinking about these things before you ever get to the point of delivering those results out to stakeholders or whoever is going to be the user. So thank you, Irene, for that. Okay, we're going to pivot once more. And Ryan, this question is for you. And so you've already helped to introduce this in the first question. But so as we think about all of this work, building algorithms, applying them in a clinical setting, taking them out into the world where we're using real world data, can you frame the legal considerations for us? So whether this is privacy, this idea of identification, de-identification of data, ethics overall, or concerns about patient consent, which is something we haven't really talked too much about. Are there protections for those who are impacted by algorithms, right? We deploy these real world systems, whether it's in the clinic or in populations. The people, the individuals who are using these algorithms for, are there protections for them? And then I have a kind of follow-up question to that, but maybe that's a good place for us to start.
Sure, thank you. I'm going to try to continue with this glass half full theme. And I just want to sort of frame things to start. One easy way of thinking about how the legal profession works is we kind of have people operating on two sides of the equation. So you have people working on the front end to help set up transactions, set up, regulatory schemes, help clients to be compliant, to make good choices, to be ethical, all of these things. And then we have the back end, which is, when things don't go the way we expect, and then we have to litigate and we have to resolve it and we have to figure out, how should things have gone and who was right and who was wrong. Obviously, the preference is always to try to fix things on the front end. And part of that is, especially in an area such as AI and dealing with bias in AI, is we are not specifically limited by what is in the law. And what I mean by that is, as I mentioned before, the law lags behind, and there are a lot of issues that have not been expressly dealt with yet under legal or regulatory schemes. But that doesn't mean that we as lawyers cannot guide our clients through business decisions, through contracting. These are powerful tools to make ethical, informed choices, set the norms, what is important to us, and how are we going to operate, so that we don't have a bad outcome and we don't have to litigate on the back end when something goes wrong. So to that end, as I said in the privacy area, this is a really complicated issue, and I could talk about it forever, and I don't want to bore people. I just want to sort of give an overview. I already mentioned the issue of de-identification, and I guess another point that I'll make about de-identification is you really have two main paths towards de-identification in most settings. One is through an expert determination that the data has been de-identified. And as the scope of technology changes, expands, what it means to be an expert also changes and expands. So we need to make sure that we're engaging experts who understand AI and machine learning and bias and all of these issues, because you could end up in a situation where someone challenges you and says, you didn't really de-identify the information because your expert wasn't really an expert. I mean, I think that would be an interesting and novel court case, but I don't think anyone wants to be the one defending that. Another path towards de-identification, there's sort of this, I call it almost a safe harbor in the law that gives you a list of data points that you can remove. And essentially it's considered like per se de-identified. I'll give you a few examples from that list. There are the usual suspects like names, geographic subdivisions, elements of dates, telephone numbers, etc. Those are kind of obvious. But it also includes things like biometric identifiers, full face photographs and comparable images, and any other unique identifying number, characteristic, or code. I mean, when we start thinking about the sort of data that we need to feed into an AI model, a lot of those are the data points that the models need. So how are we going to rely on this safe harbor to de-identify our data to feed it into these models? So we're kind of in this conundrum. The safe harbor doesn't work great in a lot of cases, and we want to make sure our experts are also up to snuff. So that's kind of privacy in a nutshell. Moving on to some of the other issues that you raised, ethics. Ethics really ties into also a discussion on consent. So I think I'll kind of group them together. The issue of informed consent is really interesting. It varies across the country. And, remember, we are a nation of many states. So we've got federal law, and then we have many state regimes underneath that. You've got interesting rules about who owns medical records. So, for example, I believe New Hampshire, actually, the law says that the patient owns the medical records, whereas most, if not all other states, say that the hospital, for example, owns the medical records. So really interesting, issue there if you're going to use a patient's data for research for a model, AI model or what have you. As far as consent goes, there are a lot of big questions. So, when do you need consent before using a patient's record in a model? When do you need consent, and how much consent do you need in all of these cases for applying a treatment that has been generated by an AI model? How much do you need to tell the patient about the AI model and what it does, and how much you relied on it as a practitioner? Did it sort of spit out some information, and then I took that and synthesized it with some other data, and I came to a clinical determination at the end? Or did the computer just say, give X drug, and I said, okay, and gave X drug? Is this your first time using it in this scenario? How much have we used it? So there are a lot of considerations there. It's hard to make a blanket statement about how much and what type of consent is required in all cases, because it's very fact dependent. But these are really important considerations that anyone who is going to move forward with, especially in a clinical setting using AI, you need to be sure to think about what type of consent you are getting, and not just necessarily meeting the law, but also meeting what is your ethical North Star here, and what sort of a institution or practitioner do I want to be? And then I think this will maybe tie into your next point, but there is another area of sort of regulation that we haven't talked about yet, and that is consumer protection and the Fair Trade Commission, FTC. The FTC, as it stands, technically the FTC Act, Section 5 of the FTC Act, does provide some baseline protection to consumers in the application of AI models. And FTC has said itself, and this is a direct quote, "Hold yourself accountable or be ready for the FTC to do it for you." And this is in relation to the use of AI models in healthcare. There are a lot of things, a lot of steps that clients and people in business and in healthcare settings can do to set themselves up for success here. And a lot of it is engaging with all of the thoughts that have been presented today. When I am going to deploy a model, whether we developed it ourselves, whether we are engaging with a vendor or some other outside person, we need to think through critically, how was this model developed? Who was involved in developing it? What data has been fed to it? Where did the data come from? How was the data obtained? These are all really important issues. And these are things that, as a sort of business protection measure, should be considered before diving into an AI model. And one other thought that I just had that I wanted to mention before, just jumping back quickly in the consent issue. I want to give, without being doom and gloom, I want to give one just touch point on, in consent, we have this case that comes up frequently in discussions of informed consent and medical ethics, and that is Henrietta Lacks. And this is a Black woman whose genomic information has been used now for decades in research, and her genetic information, she did not consent to the use of her information. And it's something that people are still grappling with, and measures have been taken to sort of address it retroactively, but you can't undo harm, right? And I guess my word of caution on this is, I don't want to say that we're necessarily in the exact same arena, but we want to be cautious of how our consent approach protects against unwittingly repeating something like this. We don't want to get down the line and say, oh, we have, gone in and taken data from a vulnerable population and use some sort of unethical methodology to do so. And now we've faced all of these, various projects on this, and everything is sort of clouded with questions about, is it even valid data if these people didn't give consent? If they, so I really want to caution that it's both about respecting people and their right to autonomy, and also about protecting your own work. It's important that you make sure that your work isn't clouded by the specter of a bad practice in the past. So these are all really important issues that I think people should be considering. And I think there's a lot we can do on the front end to take steps and make sure that we are not treading into sort of danger territory.
Yeah, wow, that was such a profound example, and I think is so necessary that the story of Henrietta Lacks and the use of information, right? And we see this much later, and the warning about the risk of algorithms applied in this way without consent. So much of this is not only consent, but transparency in these processes. That if transparent to who, and it can't just be like, the document that you say accept at the bottom. It's our role to, as developers, as individuals who understand this, to make sure that we are, right, we have a service to whatever arena, whatever domain we're in, to raise these issues as they arrive to prevent that. And so I really appreciate that example. I know that there's some legislation that has been proposed. It's mostly around transparency and this idea of you will be held accountable to explain and describe what you're doing and why it is not biased. But I think the standards being there, and Ryan, you bring up this idea of who are the experts? What do the experts look like? What's their background, and who really gets to be the decision maker or the decision makers around whether there's a pass or fail for bias or for fairness? So just so much great information there. We are right at the end of time. What I want to do is a rapid fire question, and I want to end this on glass half full, and I want to hear from each of the panelists. Ryan, we'll start with you, and then Jaya, Irene, and Seun. And I want to hear, in your work, we've seen the algorithms can reflect and amplify bias, but they also have the potential to illuminate and eliminate biases. Tell us about something that's positive, whether it relates to training or to policy, or give us that sort of glimmer that you can leave us with for panelists to find, or for the audience to find out more and read more about. So we'll just do like a really quick rapid fire, and then we'll move into our breakout session.
Sorry, thought I unmuted myself. So there is definitely room for hope here. As I said, the law is slow, but it doesn't mean the law doesn't do anything. So we do see movement. As you alluded to a few moments ago, the Algorithmic Accountability Act of 2022 is out there pending. Sort of, a question what will happen there, but the fact that we're pushing on this suggests that someday something will happen. And as you mentioned, this includes requirements to assess the impacts of automating critical decision making. The FTC will be required to create regulations that create structured guidelines rather than this kind of amorphous, make sure you're policing yourself stance, which, I would say their hands are a little tied right now because they don't have statutory guidance to go out and make these regulations. There are several other issues that it addresses. As I also mentioned before, we do see things at the state level. So California, as I mentioned, implemented these rules that essentially prohibit using outside information in conjunction with de-identified information to re-identify. And we also see really exciting, interesting things happening outside of the United States. You know, we do not exist in a vacuum. There are a lot of countries with their own legal systems, their own structures. And just to touch on one that I think is very interesting, the UK this summer is pulling together a group of regulators and agencies, and it's what they're calling a multi-agency advisory service. And the plan is to create a centralized hub for providers and innovators in the AI space, and essentially guide and support them as they develop both their own research and products, and also in the development of sort of the regulation of these products. So it's really an interesting coming together of both sides here. So we've got the scientists, the medical professionals, ethicists, all of these people, and then you also have the legal side, the government side, regulatory. And it's a novel approach. It's something I would love to see something like that happen here. So yeah, there's a lot that's exciting and interesting happening in the legal arena.
Thank you. Jaya, how about from you, and then from Irene and from Seun, give us your, the most exciting thing that's happening in a positive direction.
It's hard when you say the most exciting thing, because my brain is exploding. I'm like, there's so many exciting things to sort of talk about. But when it comes to algorithms, I think the thing that excites me most about this journey that we're doing around machine learning and the ways it interfaces with medicine, starting with that Obermeyer sort of piece that sort of made the landscape. And I'm bringing it back because we alluded to it at the top of the hour. Irene had mentioned it, but we didn't really talk a little bit about it. And it's a great example of distinct from using race specifically, when you don't use race, but you unearth race-based differences in an algorithm. So in other words, if you're using cost as a proxy for need, this algorithm was disproportionately enrolling less sick white patients into a chronic disease management program as compared to more sick Black patients. And what that algorithm did when you analyzed it is showed us other areas of bias baked into medicine when it comes to us disproportionately spending on one population with the exact same health profile as compared to another. And so in other words, when we have similar health profiles, we do spend more on average in healthcare on white patients. And so going back to what Irene alluded to in her talks around the similarity, grouping folks by health profiles and figuring out when they're not getting the same care, big data has that ability to be diagnostic in a way of current state and unearth ways in which we can then counteract those biases that we see and that we bear witness to and that we participate in medicine, but are blind to because we're not using big data to define our current states on a daily basis. And so in some ways, I see that's the promise for me to sort of as one way to chip away and dismantle how racism impacts medicine.
Thank you so
All right.
much.
I'll go ahead and chime in and say that I think that there is a growing awareness, like even the existence of this panel is incredible. And I think that when I started my PhD in 2016, fairness was sort of this archaic field that some people cared about, and it came out of the computer science theory people, which is a slightly different community than where it sits now. And the efforts that have been going on about not only having a lot of machine learning people very interested in algorithmic bias, but bringing in anthropologists, bioethicists, philosophers, and really starting to be a core thing that we teach undergrads and that we have panels about, and that we involve healthcare professionals and criminal justice people and employment professionals. There's so many people who are now being invited to the table, who are given spots to lead symposiums and have thought pieces, and all kinds of extraordinary research that comes out of these kinds of collaborations is incredibly encouraging. So I'm optimistic that it will continue and that there will continue to be an active amount of interest from many people. And even people I know that who don't focus on it as their primary topic are often thinking like, oh, we need to make sure that this, passes the bar, and we need to call in some people so that we make sure that we're on the right page of things as well. So I think that we're certainly trending in the right collaborative and inclusive direction here.
That's
So
amazing.
for us at IBC, I would say that is something that Dr. Aysola mentioned earlier is, for us, the thing that we are so excited about is the elimination of race-based medicine for our members. As I mentioned before, we believe that race is a social construct and not a biological one. So we are asking the healthcare leadership of the institutions that care for our members to eliminate race-based medicine. We're encouraging them to examine, deconstruct, retire, revise all practice guidelines because we don't want that used for our members. So, the thing that makes us smile is that our members will be treated equitably, and that something as simple as the color of their skin won't determine their care.
Thank you so much, Sean, and thank you so much. The panelists you're an inspiration to me. I've learned so much during this time and just really appreciate your time and sharing this expertise to start discussions externally. I want to thank our sponsors, and I'm going to invite you and the attendees to 2 breakout rooms. There'll be 2 breakout rooms. One of the rooms will focus on policies, programs, and procedures to work towards equity in the healthcare system. And the other will be focused on clinical and technical solutions to working towards fair analytics in healthcare. And so in the first room with policies and procedures, we'll have Ryan and Sean. And in the room for clinical and technical tools, we'll have Irene and Jaya. And so I invite you to move to one of those rooms to continue this discussion with our incredible panelists. Thank you so much.